taking the time to watch this very important video which covers the topic of preventing diabetic foot and foot amputations. It's a pleasure always to have you watching the videos that are posted on this channel. I want to applaud your effort, and I want to ask that if you've not already subscribed to the channel, you go ahead and hit the subscribe button and share this video to as many people as possible, because it's going to help with disseminating the knowledge on diabetes and its complications. It will help a lot of people in our community. So please share, subscribe, and comment on the video. Let me know what you think. Before I actually get into the video, let us reflect a little bit about diabetes and its complications. And I'll do this by walking you through some of the experiences that you might have had in your own communities or with friends and loved ones who suffer from diabetes and its complications. So the question I want to ask you is, have you as an individual been diagnosed with diabetes? Or do you know a loved one, a family member, or a friend who has diabetes or has suffered a foot amputation? Can you recall or trace the circumstances that this individual went through right up to a foot amputation, or maybe death in some cases? Having this kind of a reflection is very important to understand this talk that I'm about to give you. A little bit of history, and reflecting on that history is important. Diabetes impacts a lot of people in the world. It's a condition that is manageable. It can be managed. You can live with it and manage it successfully. But because of lack of knowledge and misconceptions about diabetes, many people suffer with it and even suffer from the complications that arise from the disease. So what I thought that I would do today is in part one of this presentation is to take you through the different types of diabetes and discuss some of the common misconceptions around the management of diabetes and diabetes itself. And we will look at some of the recommendations for self-management of diabetes. And as we go through these recommendations, we will look at some case scenarios involving studies that involve diabetics in North America. We will look at the readiness of some health systems to combat the ailment, particularly in Sub-Saharan Africa. And this will set us up for part two, which will be looking at foot self-care practices and preventing amputations. So I want to say that for today's presentation, I do this as from the perspective of a population health scientist whose interest is in studying the occurrence and distribution of diseases and health-related states. So I do not do this from the perspective of a clinician who may be interested or who is interested in diagnosis and treatment. So I will keep it very simple. I will use very little scientific jargon, because our goal here at EAN, Empower Africa Now, is to break down information that should go to every nook and corner of the world, that everyone that has an Android phone anywhere in the world, in the rural and urban areas, should be able to understand the information that we send out with less technical jargon. So So the information that I present here discusses diabetes, prevention of its complications. It does not replace any advice that you might have been provided by your healthcare provider or by your clinician. So you have to stick to that advice. We are creating awareness here in order to ensure prevention. So I just thought that I'd give you this background information as we move forward. So I will start by highlighting, looking at diabetes. You're familiar with the word diabetes. Some of you may have it, friends or family may have it. So what is diabetes? Diabetes is a group of metabolic diseases resulting from defects in insulin secretion, insulin inaction, or both. So I want you to understand these three things that I mentioned very much, because it will help you in understanding the different types of diabetes later on. Insulin, defects in insulin secretion, insulin inaction, or both. So when we discuss diabetes, you always hear about insulin around. You hear about insulin, you hear about blood glucose. So before we actually go on, what is insulin? Insulin, biologically, insulin is a hormone. It's a hormone that is secreted by our bodies, the organs, which I'm not going into it. Insulin basically is responsible for regulating the amount of glucose in our blood. Okay? Insulin regulates the amount of sugar, in simple terms, glucose in our blood. So when that is not regulated as our system will expect, we have these complications that we'll discuss about. So insulin, glucose, very important. Why is diabetes important, a condition that we really need to focus on? It's because it impacts us in different ways. So chronic diabetes, how does diabetes affect us? When diabetes becomes chronic, it can affect the eyes, the kidneys, the nerves, the heart, and the blood vessels. So it can actually lead to long-term damage, dysfunction, and failure of the different organs, especially the eyes, the kidneys, the nerves, the heart, and even blood vessels. It can also impact our faith, such that you may have what is referred to as diabetic foot or diabetic ulcers. These can lead to amputations if poorly managed. So that is why we need to pay a lot of attention to this condition. There are different types of diabetes, and I'm just not going to go into the diagnosis, but I will mention them for the purpose of understanding this presentation. You have what we call gestational diabetes. Most of you, especially women, will know about this. Gestational diabetes occurs in some women during pregnancy, and it is generally expected to disappear following delivery. Okay, so when it is not resolved following delivery, it then becomes what we can then classify it as type 2 diabetes. So if you are a pregnant woman and you've been diagnosed with gestational diabetes, you should expect this to be resolved following delivery. Your medical practitioner, your clinicians will guide you on how to manage this condition. When this does not resolve following delivery, it then becomes what we call type 2 diabetes, which I will discuss further down. So what is important here is that following delivery, you need to double check to be sure that you are free of gestational diabetes. Otherwise, your healthcare practitioner will tell you how to manage the condition forward. So gestational diabetes in women. There is another type of diabetes that is referred to as type 1 diabetes. How is it caused? The cause is an absolute deficiency of insulin secretion. I talked to you earlier on about organs secreting insulin to regulate the amount of glucose in the body. So in this case, your body does not secrete enough insulin as needed. So people who have type 1 diabetes will often have to inject insulin to compensate for the absolute deficiency. Okay? And so this type of diabetes accounts for about 5 to 10% of all diabetes cases globally. That is type 1 diabetes. The other category of diabetes is type 2 diabetes, which is caused by a combination of factors. It can result from insulin inaction and an inadequate compensatory insulin secretory response. Insulin inaction and inadequate compensatory insulin response. So what does this mean? In simple terms, your body is unable to adequately use the insulin it secretes. This is what it is. And so for type 2 diabetes, the way it is managed is usually not by injecting insulin. The healthcare team will propose various ways that you manage it. It could be through medication and a combination of other factors. Type 2 diabetes, which is really my focus, is often referred to as asymptomatic. What does that mean? It means that you can have it for a very long time without developing any symptoms. And that is why it is often referred to as a silent killer, because you may not know it if you don't screen. And so people with type 2 diabetes often gain weight, and they can sometimes be obese. Okay? In terms of the distribution, prevalence, how many cases, what is the distribution of type 2 diabetes relative to the other cases? About 90 to 95% of people with diabetes is the type 2 diabetes category. In other words, type 2 diabetes accounts for 90 to 95% of all diabetes cases. It's important to take note of that. So now that we have talked about the different types of diabetes, coming back to our reflection, if you have been diagnosed with diabetes, what type of diabetes do you have? Is it gestational in the case of pregnancy? Is it type 1 diabetes? And if so, are you on insulin? Whether injecting it yourself or being helped by a healthcare practitioner. Otherwise, are you diagnosed with type 2 diabetes, where you are probably managing it through medication and other recommendations that have been made available to you by your healthcare team? It is important to know what type of diabetes you may have been diagnosed with or your family member is having, in order to properly know how it is supposed to be managed. So now that I've presented the types of diabetes, I want to emphasize that it is a condition that will be managed or is managed on a case-by-case basis, depending on the type that you are diagnosed with, and so your healthcare providers will provide a management plan and help you with that. Let us now look at some of the misconceptions. As I said before, misconceptions, lack of knowledge about these conditions really can impact how they are managed, and if poorly managed can lead to very severe complications. So I would like to talk a little bit about the misconceptions around this. I know it's not an interactive presentation where I like to hear from you, but it would have been good to associate you with voting on these misconceptions, to know your own level, test your own level of knowledge around diabetes. So what I would say about misconceptions is that the misconceptions vary by community. They are not limited by geography. You have misconceptions even in communities with high levels of literacy. It's not about just literacy, it's literacy or knowledge about the condition. So being literate per se does not mean that you basically have the knowledge around this condition. So I'm going to talk to you about a study of low-income minorities in New York, whereby misconceptions around the condition were very prevalent. Okay, so in this study, patients who were diagnosed with diabetes were asked a series of questions in a survey, and some of the questions were related to whether they will always have diabetes, whether they can be cured of diabetes, whether they should stop taking their medications when blood glucose levels were normal, and whether they only have diabetes when the blood glucose levels are high. And you'll be surprised to get some of the responses that came out of this study. So in this study, by the way, why do we call it misconceptions? Just to let you know before we go into the finding, they are misconceptions because they are not true. They are wrong in this thinking, in their way of thinking. And by thinking that way, it can definitely impact their health-seeking behaviors to combat the condition that they have. So in this study, participants thought that they will not always have diabetes. You see, they have diabetes, and they thought that they would not always have diabetes. They thought that they would be, it would disappear at some point. Well, this can happen, but it depends on how you manage it. And that is why I keep emphasizing that it's a condition that requires managing. And so we must have that sink into our minds to be able to comprehend this. In other situations, 29%, in this particular study, again, 29% of the participants thought that doctors will cure them of their diabetes. Again, cure versus management. That is what I want to emphasize in this. 29% thought that they would be cured from diabetes. So what implications does this kind of finding have? It means if they visit their doctor, have maybe a recommendation. By the way, these were type 2 diabetic patients. If they had a recommendation to take medication, and you have this kind of a misconception, it may impact them in a way that they decide not to follow up after completing their medications. So you see why this is important. Some thought, 23% of the participants in this study, they thought that there is no need to take diabetes medication when glucose levels are normal. No. You have to. Because having a normal glucose level is just as a result of the medications that you are taking and other recommendations regulating it to that normality, to achieve normality. So you still have to take your medication. Okay? So this is a misconception. It is only your medical advisor that can, upon having certain controls, tell you to stop certain medications or not. Okay? So another misconception from this study was that some believe that they have diabetes only when glucose levels are high. In fact, 12% believe that. 12% believe that. In fact, diabetes, of course, I see why they believe that way, because diabetes is diagnosed through the blood glucose levels in your body, but it is this correction of the high blood glucose levels that brings it to lower levels, and you have to keep managing it to make sure that it is resolved. Okay, so understanding this is very important, because nowadays, due to advancements in technology, we have glucometers that you can even manage your blood glucose or measure the level of glucose in your blood at home, and having to do misinterpretations versus high and low, and determine by yourself whether you are diabetic or not diabetic can be deleterious. It cannot be very helpful in the way you manage this condition. So these are some of the misconceptions that we found in this study. There are others that I have not synthesized here. I'll invite you to ask, what are your own thoughts about diabetes? What do you think is the cause? What do you think leads to the foot amputation or the diabetic foot and subsequent foot amputations? There are a lot of beliefs around these things that, if not well understood, can impact the way that prevention programs are prepared to combat this condition. And that is why I highlight this issue of misconceptions here. So let us now talk a little bit about having addressed the misconceptions. Let us look about the self-management recommendations. So what happens when you have diabetes? We've talked about the gestational, which will resolve after pregnancy. We've talked about type 1 diabetes, which is resolved through insulin injection. Now, type 2 diabetes, what are the recommendations for self-care? For self-care, it has been, there are 5 scientifically driven recommendations for self-care in type 2 diabetes. And these recommendations involve the dietary intake, that is what you consume, glucose monitoring, just as I've mentioned. What are the levels of glucose in your blood? There is also physical activity. There's a recommendation to be involved in exercise. Of course, vigorous, regular exercise. There is also the medication management. If you are put on medication, do you adhere to your medication? Are you taking your medication as it should be? This is what I'm referring to as medication management. And then there is foot self-care. How you care for your feet is important. Foot self-care is involved. It reduces the risk of the lower extremity complications involving amputations. So these 5 criteria are important for managing type 2 diabetes. And so you see that in different healthcare systems, you may have a team of experts coming together to provide management for type 2 diabetes. You may have a podiatrist, you may have a dietitian who would make recommendations for nutrition. You may have nurses, all put together as a team to manage diabetes. In some situations, all of this information from the podiatrist, from the dietitian, from the nurses can be put together in an education package and handed to you through an educator. So there are different ways, okay? I repeat, in the case where the expertise is lacking, for example, a podiatrist, a dietitian, and other endocrinologists and other experts, some systems can put this material together into a booklet or an educational program for training of patients on how to self-manage their diabetes. Of course, we follow up from the healthcare system. So what I will ask you is, if you are having any of these conditions or any of your loved ones, how are they managing it? Are they doing self-care and returning to their healthcare providers for advice, or how is it being managed? This is very important. The 5 criteria for managing diabetes, type 2 diabetes, important. So now that we have discussed the 5 criteria for managing for self-care in type 2 diabetes, what do we know about self-management of diabetes? I would like to use the case scenario of Sub-Saharan Africa and present some studies that have been conducted out there for self-management of type 2 diabetes. And I look at this from the perspective of what I call bringing studies together and presenting a summary of the findings. We refer to this as a systematic literature review. So it's a kind of research whereby rather than in the absence of primary data, or we basically collect all studies that have been conducted in a geographic area that meets certain criteria, in this case self-management of type 2 diabetes, and we bring these studies together and we synthesize the findings in a systematic, in a logical way, and present what the authors found. So in this 2016 study, the authors selected a series of reviewed the literature and found that 43 studies conducted out of Sub-Saharan Africa met the criteria to be able to understand self-management of diabetes. What were the key findings? This is what is interesting to the audience that this presentation is intended for. All 43 studies, the main findings from these studies were that patients with type 2 diabetes, they rarely monitored their glucose levels. You've seen the importance of monitoring glucose levels as presented above. So these studies found that patients with type 2 diabetes, they rarely monitored their glucose levels. We will understand some of the reasons later. They also had low frequency or duration of physical activity. That is, low frequency of physical activity, exercise. There was only moderate adherence or keeping up with medications and the dietary behavior. What does this mean? That means the recommendations of what to eat or taking medication, recommendation on how to take their medication, how regular to take their medication, and what to eat. They only moderately adhere to these recommendations. They were not following this as much as they should keep to those recommendations. That is what this means. Also, they found that most of the patients had poor knowledge regarding diabetes and the related complications, and that some sought traditional herbal medicine besides their biomedical treatment. I want to talk a little bit about seeking herbal traditional medicines. It's common practice to seek herbal traditional medicines. I have no problem with that. In fact, it can be helpful in resolving some situations. But the problem is with a condition as like diabetes that I'm talking about, that we know that you have to constantly monitor the blood glucose level. If you seek traditional herbal medication besides your advice from your medical practitioner and you do not follow it, you may not really know what is happening with your system. Or even if it works, you may not know what has caused the condition to be resolved. So it's important, regardless of what you have adopted as therapy, to follow the advice of your healthcare practitioner. So in summary, What did these 43 studies find about self-management of type 2 diabetes in Sub-Saharan Africa? Again, there was poor monitoring of glucose level, low frequency of exercise, low adherence to medication regimen and dietary intake, and also poor knowledge of diabetes and the related complications. So the status of research and management, self-management of type 2 diabetes in Sub-Saharan Africa is poor. It's not only in Sub-Saharan Africa. Globally, there is need for improvement. But we know that in a study by Stephanie and colleagues in 2008, they emphasized that the percentage of people who are able to self-monitor glucose level at home was poor. The percentage keeping with medication is poor. These are indicators that you can look at the level of individuals to ask yourself, how well are we in terms of combating this condition? Okay, so what these studies show is that there is an effort to manage diabetes in Sub-Saharan Africa, but that needs to be improved. Though limited, there is need to build on the current efforts to improve, to scale up management. And I'm going to talk a little more about that. So how do you scale up management? What are some of the studies out there that have presented interventions for scaling up? In another systematic literature review that I'm going to present here, this one was conducted by Linda Koffer and colleagues in 2018. In fact, these investigators are from the National Institute of Diabetes and Digestive and Kidney Diseases, which is part of the National Institute of Health in the United States of America. So these investigators conducted a systematic literature review, again, gathering all studies that address self-care in type 2 diabetes and synthesized the results and presented the findings. What they found was, first of all, they retained 55 studies covering different aspects of diabetes care in Sub-Saharan Africa. And what these investigators found were different issues related to self-management of diabetes. They include scarcity of glucometers, the equipment that is used to measure glucose in the blood. There were issues of lack of testing strips, the capacity to measure HbA1c, okay? HbA1c, which is also referred to as glycosylated hemoglobin, that is the insulin, okay? So there was lack of capacity to measure this. We know that this is essential tool to the diagnosis of diabetes. And when you are unable to measure HbA1c, there can be issues of misclassification, whereby you can erroneously misclassify some people as having diabetes, that's false positive, meanwhile they do not. Or you can erroneously misclassify some as not having diabetes, meanwhile they do. So it is very important to be able to measure HbA1c. Studies have shown that lack of access to HbA1c testing can lead to poor glucose control. And so these are some of the issues that these investigators highlighted. I would like to discuss each of them one at a time to really emphasize the details of the study. These researchers from the National Institute of Health, they synthesized the results from the 55 studies, and they identified different issues that impacted self-management of diabetes in Sub-Saharan Africa. One of the issues was that of the capacity to diagnose diabetes. there was poor diagnosis capacity. And the reasons behind this included scarcity of glucometers. There were issues of lack of testing strips, the capacity to measure HbA1c. When you are unable to measure HbA1c, it can lead to misclassification, whereby you can maybe classify someone as having diabetes, meanwhile they do not. That represents what we call a false positive. Or you can erroneously classify someone as not having diabetes while they do. So that is a false negative. So these issues, they were prevalent in these studies. It has been shown that lack of access to HbA1c testing can lead to poor glucose monitoring, poor glucose control. So this is the issue that they presented around, that they found around a diagnosis. The next issue is that of access to medication for diabetic patients. Does availability of medication mean access? It doesn't. We know that diabetic medications out there, but they may not be accessible. So the issues related to access, lack of availability in health centers. We know with our district health systems that is characteristic of the healthcare systems in Sub-Saharan Africa. You go to a healthcare center, you diagnose, you procure medications. So these medications were not available in some health centers. There's also the issue of even when the medications are available, it constitutes a large expense to the patients. So diabetic medications are expensive. So this calls into mind issues of maybe subsidizing medication to ensure affordability by the population. If that is what some governments are able to do or can do, that will be formidable. So there is also inadequate storage conditions. Medication are stored under certain conditions, and in some areas, even with power availability, there is also issues of storage. So the investigators emphasize the fact that these issues of access is primordial in the rural areas. So we must take note of that. So another thing that they found is the capacity of health workers to manage diabetes. We know that there are different professionals involved in its management: doctors, non-medical officers, medical officers, nurse practitioners. So all of this, the capacity of health workers to manage diabetes was another issue. They found in this series of studies that medical doctors were better positioned and they had the capacity than the other healthcare professionals to manage diabetes. However, one of the things I must bring to your attention is the fact that the healthcare systems are characterized by, when you look at the doctors, we have a high patient to doctor ratio. That means the number of patients that are received by one doctor, in some cases ranging from 1,500 to one doctor. Okay, so the high patient to doctor ratio can also impact the quality of care as well as the attention that these doctors can have to manage specific conditions. They are already dealing with a lot of all other illnesses. And so these are all factors that are worth considering when elaborating a management plan for diabetes. So overall, what can we draw from this synthesis of 55 studies from these NIH researchers? They actually concluded that though there has been significant developments in chronic health systems in Sub-Saharan Africa, especially diabetes, there are major deficiencies in the capacity to manage diabetes, and that with the prevalence or with the availability of pilot studies, pilot projects that have been carried out there, that the different healthcare systems can build on these pilot studies to enhance and strengthen the management capacity for diabetes. In fact, they cited some of those pilot studies. You will see in Kenya, for example, Kenya and Democratic Republic of Congo, a pilot study involving cell phone-based home monitoring glucose programs. It's a pilot study that was conducted there that is working. So whereby we're using cell phone home-based monitoring of glucose programs, training people how to monitor it. So that is a pilot study that took place in Kenya and the Democratic Republic of Congo. In Kenya and Nigeria, for example, they cited a home-based screening program for diabetes. That was another pilot program. In Kenya and Cameroon, for example, they cited the self-monitoring blood glucose program. Meanwhile, in South Africa, there was mobile testing units. So units that will go from one community to another to test for diabetes. So these are all pilot programs that they thought that it can be built upon. Meanwhile, in Rwanda and Mozambique, for example, they highlighted a program based on partnerships and systematic care that has been piloted to also strengthen and enhance management of type 2 diabetes. So it does not suffice to end at the level of pilot. The big question that we ask ourselves, that we ask ourselves following this pilot is that, has there been a rollout to the broader communities following this pilot? Has these programs been rolled out to the national territory, or did it end at the local level? We know what a pilot is. A pilot is a small project where you test in a community or involving a group of individuals. You can draw from the lessons learned during that pilot, you improve it. If it works, you can then roll out. So these programs have been shown to be effective. So from a healthcare system level, have these programs been rolled out, or is there a plan to roll out this program? So that was the main conclusion that came out from a synthesis of these 55 studies, that basing on these pilots, they can scale up and integrate diabetes management in other programs to make sure that the management of the diabetic epidemic, an impending pandemic in Sub-Saharan Africa and other parts of the world, that it can be managed. So to you that is watching, at a level of an individual, or let me say, if you are a health decision maker, the question I ask you is, you may have some disease management programs in your communities, be it HIV screening, voluntary screening and testing, tuberculosis care models. Which chronic disease care arrangement is available in your own home countries, in your community, that you can build upon to integrate the diabetes management in Sub-Saharan Africa, for example? This is the take-home message that I leave you with. So at this level, what I would like to do, having presented self-care management and the status of management at health system level, I now want to get back to the crux of the matter, which is about the diabetic foot and amputations. What interests me as far as this presentation, part one of this presentation is concerned. The complications resulting from poor management or inability to manage diabetes can be very devastating, and that is my focus. That is why I emphasize that this video is about awareness. You have to circulate it. You have to make sure that you pull some relevant information from it, and know that it's a condition that can be managed. You must not develop anxiety, unnecessary anxiety, if you have been diagnosed with diabetes, or even your loved one. It is manageable. But the beliefs that we have and misconceptions that may be prevalent in some communities will impact how this is managed. So let us talk a little bit about the diabetic foot. What is it? In discussing diabetes, complications from diabetes, you will often hear about peripheral neuropathy. I'm not going to get into a lot about that, but this is really the impact on the lower limbs, especially the feet. Okay, this is the impact, long-term impact. The chronic diabetes impacts this. So how does it manifest itself? How do you begin to feel, or how do you begin to notice that you are heading in this direction? You begin to lose the sense of touch. You begin to lose the sense of touch. When we touch, you touch your body, be it your hand, your feet, you have that feeling of touch. So you begin to lose the sense of touch, such that you experience abnormal feeling and numbness of the feet. Numbness of the feet. Take this balloon, for example. This balloon, when you touch this balloon, if you wear your feet and you start to feel some numbness, okay, and losing that sense of touch, you are starting to get into danger. If you are experiencing any of this and you haven't consulted, you need to seek care as fast as possible, because you are starting to move into the danger zone. And I'm not saying that all situations where you may have numbness of the feet are as a result of diabetes. No, this is not what I'm saying. But if you have been diagnosed with diabetes and you start to feel numbness of your feet over time, you start to lose the sense of touch, and you have not sought care. Maybe you were using some herbal traditional therapy and you rely on it, maybe because of some belief. You need to seek medical care as fast as possible, so that a health care plan can be put for you to try to reverse or contain this situation. This is very important. And your healthcare practitioner, your clinician, doctor or nurse will give you a lot more of this information. I aim at the level of awareness and prevention. This is what starts to happen. So these conditions that I mentioned, numbness, losing the sense of touch, they can further develop into a diabetic ulcer. It can develop into a diabetic ulcer, or what we simply call a diabetic foot disease. And what is it? When we say diabetic foot, what is it in practical terms? Aside from the swelling that you may feel, you see that diabetic foot is actually an abnormal distribution of the internal bone pressure on the foot. You know, we have bones on our foot. Those that have done biology in more detail, they can tell you in simple terms the different bones, metatarsals and all whatnot. So our weight is distributed on our feet. Just like when you press the balloon that I'm showing here, you see its shape changes. Its shape changes. If you press it too much, it can break. So a diabetic foot results in an abnormal distribution of the internal bone pressure on the foot. So about 16 to 86% of people with diabetes can experience diabetic foot. It's a wide range. 16 to 86% of people with type 2 diabetes, they can experience diabetic foot. So you see from this explanation that I've given before, you see that it can be prevented depending on how you manage. Before we actually move on, now that I've mentioned numbness of the feet, I want you who is watching right now out there, if if you have been diagnosed with diabetes, type 2 diabetes, can you experiment right now? Can you touch your feet? Can you touch your feet? Do you have the sense of touch? The feeling? Do you have that sense that you are touching that feet? Are you feeling it? If it's your family member, friend or loved one, can you ask them to feel it? If they are losing that sense of touch or feeling some kind of numbness, I urge you to ask them to consult their healthcare provider as soon as possible. If they have been diagnosed with diabetes before, or even if you have not been diagnosed, or even if you have never consulted and been diagnosed for diabetes and you are feeling that, you need to visit your healthcare practitioner. Go to the hospital, go to the clinic and complain. This practical exercise is very important as we move forward. Okay. So, the reason why I emphasize this is because of the burden that is posed by the complications of diabetes. Diabetic foot complications are chronic and they are costly. They impact health expenditures, that is cost. They can lead to amputations and even death. And to help you understand this, I want to present to you just a summary of some of the data around this. When we look at persons who've had diabetic foot ulcers compared to those with no diabetic foot ulcers, studies on health expenditures have actually shown that amongst people who are diagnosed with diabetes, those that develop what we call DFU, that is diabetic foot ulcers, their health expenditure, that is the amount of money spent on health care, is 5 times more than the other people with diabetes who did not develop diabetic foot ulcers. So you see how even having diabetes and not developing any of the lower extremity complications can save you some money if you can probably just manage the condition. But once you develop this condition, it's going to increase your healthcare costs. It is also been shown that as far as foot amputations are concerned, people with diabetes, in fact, foot amputations are 10 to 20 times more common in people with diabetes compared to people with no diabetes. So there can be foot amputations as a result of other factors, maybe accidents, elephantiasis, or maybe other issues that arise. But as far as diabetes is concerned, if you look at just looking at data at a higher level, and you see that foot amputations are 10 to 20 times higher in people with diabetes than people without diabetes, it raises an eyebrow. What is happening? We call this an association. There's a strong association in this, and that is why you need to be very informed and seek care around this. That's why I drive this message around awareness and prevention. Also, amputations do not end there. There's a psychosocial, psychological impact. Foot amputations can lead to loss in productivity, not only at the individual level, at the macro level. If you look at country-wise, if you have so many people in a country with foot amputations, what is it doing to the local economy and even the economy of the country? So there is loss to productivity. There is reduction in quality of life. People tend to be dependent, for example, or cannot even perform some of the things that were the duties and roles that they had to perform in the community had there been no foot amputation. So quality of life becomes very important here. And when you lose quality of life, there are other things, other conditions that become associated. Foot amputation, lack of physical activity, you start to gain weight maybe, and so on and so forth. I don't want to go into other conditions here, but it's been shown that there's high levels of multimorbidity with people who have suffered foot amputations. That means even on top of your diabetes, you have other conditions associated with it. So here I just want to emphasize loss in productivity, reduction in quality of life, and even death of the patient. In most cases, in some cases, foot amputations can end up with the patient dying. Do you know anyone in your community, family or friend, who has died following a foot amputation? So before I actually wrap up this video, if you, a friend or a family member, has recently suffered a foot amputation, some of which has resulted to death of the patient, for you to properly understand this awareness message that I'm passing to you, I want you to trace back and think about the circumstances that they went through, from diagnosis of diabetes to how they managed it, up till when they had a foot disease and then an amputation. Think about the health, the expenditures, the quality of life post-amputation, and for the situations that led to death, what happened. This reflection is very important for you to be able to help others dispel some of the beliefs and misconceptions that are preventing people from seeking care to properly manage their diabetes. I hope it's been helpful, and that you can share this message to reach as many people as possible. I want to bring to you just one other finding that can really much impact the prevention of amputations. So before I close, I want to bring to you just one additional finding, prevention strategy that can be very helpful as far as amputations are concerned. I mentioned the 5 criteria, self-care recommendations, type 2 diabetics. Research has shown that working only on one, for example, intensive blood glucose management alone, that is the HbA1c, being able to effectively manage your blood glucose level can reduce the risk of an amputation by 35% alone. Just that. So you see how if you are able to do this and manage all the other conditions, you can resolve your diabetic situation without having to develop any anxieties. Often the anxieties around these diseases may cause more chaos than even concentrating on managing it. So the International Diabetes Federation and other bodies, they have recommendations to increase awareness and knowledge of healthcare professionals about the management of diabetic foot complications. It is recommended to conduct regular screening and identifying at-risk feet. For those who manage their blood glucose level at home, following recommendations from their healthcare practitioners, whether you're being asked to pay a visit to the hospital or to the clinic every 3 months or once a year for regular screening of feet, just follow that advice and know that it is a condition that is manageable. So I will end this presentation by having a very short recap of what we have presented here in part 1 of this series, preventing diabetic foot and foot amputations. I have highlighted the different types of diabetes: gestational, type 1 diabetes, and type 2 diabetes. I mentioned that I would not emphasize on the diagnosis because we'll leave it to the clinicians. I'd advise that you follow the advice of your healthcare practitioner and adhere to it as much as possible. I, however, mentioned the 5 self-care recommendations for self-management of diabetes. That includes dietary intake, glucose monitoring, physical activity, medication management, and food self-care, which is very important for risk reduction. I have also presented a systematic review of studies, case scenarios in Sub-Saharan Africa, where the studies found that patients rarely monitored their blood glucose levels, they had low frequency of physical activity, and they did not, there was only moderate adherence to the recommendations for taking their medication and their dietary intake, that's food intake. And they had poor knowledge regarding diabetes and related misconceptions. I mentioned the study in New York whereby there were misconceptions about diabetes, where some of the participants, patients diagnosed with diabetes, thought that their doctor would cure them out of diabetes, and so on and so forth. I have mentioned the feeling of numbness, the loss of sense of touch of your feet, and the fact that if you're experiencing that, you need to seek care as much as possible. What we draw as a conclusion from these studies in Sub-Saharan Africa is the fact that food self-care was hardly mentioned in these studies. Yet, food self-care is known to prevent diabetic foot and its complications that lead to amputations and all the issues associated with it. Amputations, again, can reduce quality of life. They are high cost, high healthcare cost, and it can lead to death. At this point, having presented this background information, I think we have enough to go into the next part 2, which focuses on the food self-care. And the question I ask is, what are the food self-care practices that you should engage in to make sure that you do not develop lower extremity complications and subsequent amputations? That will be the subject of part 2. I hope this video has been useful. Please like it, comment, share, and if you have not yet subscribed, I urge you to hit the subscribe button right down below such that you will not miss any information that we are sending out. If you're interested in seeing some of what we do, you can also visit our website. I invite you to visit our website at www.eanresearch.com. eanresearch.com. You can visit the website, subscribe to some of the programs that we are offering out there, and you can also reach me by email at en@eanresearch.com. Thank you very much for watching, and I hope that this information will reach the wider community, the grassroots, the rural areas, and it will impact and lead to improvements in health. Thank you.